Today, we're very happy to have founding partner David Cutner of the elder law and estate planning firm of Lamson and Cutner to talk about accessing Medicaid and finding the right care. He's joined by Tara Lovett, who is Lamson and Cutner's Director of Client Care and Advocacy, and Cindy Custer will be on hand to handle the chat. So we normally do get a lot of questions. Please put them into the chat and they will handle them as they go along. And with that, I'm going to hand it over to David and take it from there.
Okay, thank you very much, Matt. I think we'll have an interesting afternoon here talking about accessing community Medicaid and finding the right care. So let me see if I can share my screen here.
And David, I'm just going to tell everybody that, so if you can please ask your questions in the chat. I'm going to be moderating the chat. I'm going to, close off my computer, sorry, my video. But yeah, so if you have questions, please ask them in the chat, and either I'll ask them at that moment, if it's the right moment, or I'll wait until there's a break and then I'll ask him then. So thank you.
Okay, very good. Thank you, Cindy. And let's get started. So hope you all can see the PowerPoint here. This is our law firm, Lamson and Cutner. We're in Manhattan and we're in Westchester County. So thank you to PSS for sponsoring this event. Hope it's a good one. Let's jump right in. I think the first thing to know, and I have to say I was shocked when I saw this statistic for the first time. This comes from the U.S. Department of Health. And according to their statistics, for people over the age of 65, 7 out of 10 will need some kind of long-term care at some point in their lives. And about 4 out of 10 will need nursing home care. So if we put those percentages together with the cost of long-term care, we have a huge financial risk. And I think for most seniors, this is your biggest financial risk right here, long-term care. So let's take a little bit closer look now at Medicare, because people over 65 and some under 65, if they're disabled, have Medicare. And we find that a lot of our clients have the impression that if they need long-term care, Medicare is going to cover it. Well, sorry, Medicare does not cover long-term care. It's not to say it isn't a great program. It is. It's really excellent medical care. Doctors, hospitals, rehabilitation, and so on. Very, very good medical insurance. One thing to be careful about, though, is if you or a family member is in rehab, a lot of people have the impression that they have a right to 100 days. We need to recognize that you have up to 100 days. So rehab is often much shorter. It really depends on what the doctors have to say. So if you're in rehab, don't think that you're automatically getting 100 days. You may need to deal with the long-term care issue a lot sooner than you think. So if we do need long-term care, who is going to pay for it? Well, here's the list, and that's it. Private pay, or have our children pay. We probably don't want either of those options, and we probably can't afford to pay, and our children probably can't afford to pay. It's just so expensive. Long-term care insurance, for those who have it, probably you don't. Most people don't. Really only a very small percentage of the population has long-term care insurance, probably less than 3%. And those who do, often the insurance turns out to be inadequate. I saw a client just this week who had a long-term care policy and who told me, well, I'm all set. I don't need to worry about long-term care. I have insurance. And I said, great, let me take a look at your insurance policy. Well, the benefit was $43 a day. Okay, $43 a day would barely pay for 2 hours of home care. So we have to ask ourselves, if we have a policy where the benefit is a small amount, whether it's $43 or $100 or $150, it just doesn't go very far. Then the question becomes, well, if you need more care than the insurance is going to cover, how are you going to pay for it? And if the answer is, well, I guess I'll have to take money out of savings, that's not a good answer. You're going to wind up spending down your life savings, even with the insurance policy. So if you have it or thinking about buying long-term care insurance, you really want to give some thought to how much coverage you can afford and how close you're going to get to covering the actual cost. And if it falls short, where the money's coming from to cover the gap. So that leaves us with Medicaid, and that's what we're going to talk about today. Fortunately, in New York, we have a really excellent Medicaid program. Medicaid is a partnership between the federal government and the state governments, and it matters a lot how much the state is putting into its Medicaid program and what its laws look like. And the differences among the states are really big. It's almost shocking how different the Medicaid program is from one state to another. But we're lucky here in New York. We have undoubtedly the best program. It is the best funded. There's more money per capita, more providers than any other state can offer. So here's just a kind of broad scope of what Community Medicaid covers. I'm distinguishing Community Medicaid from nursing home. So nursing home, we want to think of as something different. Medicaid nursing home, the rules are different and the eligibility is different. Today, we're going to be talking about Community Medicaid because that's what covers home care, but it also covers lots of other things, as you can see on this slide, including adult daycare and assisted living care. So how do we become eligible? How do we access the Community Medicaid program in New York? So we need to distinguish, first of all, between assets and income. Well, Medicaid uses the word resources for assets, but the focus for eligibility purposes is on your assets. So Medicaid is going to look at what's in your checking account, your savings account, investments and stocks, bonds, mutual funds, cash value of life insurance, real property, co-ops, and so on. And all you can have in your name is a maximum of $31,175. That's the eligibility level for this year, 2024. That number is probably going to change for 2025. If it does and when it does, it probably is not going to change by very much. It may go up a little bit, but probably not much. So you can see it's a low number in order to be eligible. However, Medicaid laws in New York give us a pathway to become eligible, even if we currently are not. As you see on this slide, income is not a factor of eligibility, but it doesn't get ignored. Medicaid does have a monthly income limit of $1,732. Again, that number is going to change next year, but again, probably not by much. So if we have more monthly income than the Medicaid limit, it's not going to make us ineligible. It just leaves us with a choice. Do we want to contribute the so-called surplus, the amount above the Medicaid limit? Do we want to contribute it to the cost of care, or do we want to essentially keep it by putting it in a pooled income trust account? And as you can imagine, almost every client of our firm certainly is going to have a pooled income trust account. So the pooled income trust is a special kind of trust that is operated by nonprofit organizations that are authorized by the state to conduct these trusts. So if you are a Medicaid recipient, a community Medicaid recipient, you can't use this if you're in a nursing home, but for any of the community programs, you can put your surplus income into your pooled income trust account, and you can use it for anything you want as long as you're spending it on yourself. So you can send your bills to the trust and ask them to pay your rent, your co-op fees, your condo fees, your mortgage, your credit cards, your utility bills, and so on. But again, it's not limited to necessities. So you want to buy yourself a new TV set, a new refrigerator, redecorate the apartment. You can, as long as it's for you. Some of the pooled trusts will actually give you a debit card. So if you go to the market or the drugstore, you can simply charge the card directly to your pooled income trust account. So a very useful thing that we have in New York, the pooled income trust. Again, its purpose is to protect your so-called surplus income if you are benefiting from the Medicaid program. So a couple of frequently asked questions. What about the look back? Well, this is why I distinguished nursing home Medicaid from community Medicaid, because nursing home Medicaid does have a look back, a 5-year look back. But for community Medicaid, we do not have a look back. We've never had a look back in New York for community Medicaid. Other states do, we don't. There's been a lot of talk about a look back for community Medicaid. Back in early 2020, the New York State Legislature enacted a look back for community Medicaid, but it's never been implemented. There's been talk about implementing it next year. I don't know whether that's going to happen. I personally doubt it, but again, the official word is that there may be implementation of a 30-month look back next year. Anyway, we shall see. So let's say you're someone who has more than $31,175, but you need very expensive long-term care. AIDS in the home, it adds up. because it's not just today and tomorrow, it's every day. So you multiply, 8 hours, 10 hours times whatever the hourly fee is, times 52 weeks or 12 months. That's a big number. So if we want to become eligible for the Community Medicaid program, we're going to have to move money out of our name. So if we transfer assets to somebody else, another family member, or possibly a trust, is there anything wrong with that? Answer, no. Nobody's going to get in trouble. Nobody's going to get sued. Nobody's going to say you did something bad or unethical. This is what's permitted under New York law. So if New York ever decides that we do not want people to be able to transfer ownership of money and property in order to become eligible for the Medicaid program, the government could do that, but they haven't. And this is what the law has been for decades. So the question here, if we need to become or want to become eligible for the Medicaid program, and we have more assets than the Medicaid limit, again, currently $31,175, to whom should we transfer our money and our property?
David,
So,
David,
yes.
sorry, can I just, there are a couple of questions in the Q&A that I would like to ask you that are pertinent to what you've already been speaking to. Okay, ready?
I'm ready. Go ahead.
So question number one, for income, does Medicaid consider pension and Social Security income as part of your income?
Yes, absolutely. Anything that would be ordinary income for a tax return, yes, absolutely. Social Security, pension, distributions from retirement plans, rents, royalties, anything that is ordinary income is going to be counted by Medicaid.
Okay, good. Number two, this is a good one. If I'm the power of attorney, do I have access to the pooled income trust?
Well, that's a very good question, and it depends upon the scope of authority that is granted to you as agent. And I think a lot of people assume that the power of attorney is a kind of standard document. There are certain things that are standard about powers of attorney in order to comply with New York law. But one thing that isn't necessarily standard is the scope of authority granted to the agent. And that is critical with the power of attorney. We want to know that the agent is going to be able to do the things that the agent may need to do to act in the best interest of the person who granted that power of attorney. So the power of attorney may or may not give authority to the agent to deal with the pooled income trust. It may or may not give the agent authority to sign a Medicaid application or obtain the documents needed for a Medicaid application. So very, very important question. If there is a power of attorney, is it adequate for the intended purposes? And that gets us right to the issue of the scope of authority.
Yeah. Okay, good. Does someone have to lower their bank balance or transfer the money in order to become eligible for Medicaid? I believe you already addressed this, but.
Well, I'm not sure what they mean by lower the bank balance, but if we mean spend the money, yes, you can spend the money. So, pay off your credit card bills or whatever it is, buy yourself a new TV set or a new refrigerator, sure, you can do any of that. And if that reduces your balance, that's fine. Or you can transfer money, as I said, to family members or friends or to a trust. But if you want to qualify for Medicaid, somehow, some way, you are going to need to be able to prove that you have no more than $31,175 in resources. Okay. Any other questions right now, Cindy?
The last one, sorry, is this is the question is a community trust revocable? And I believe she probably means a community Medicaid trust.
Well, I'm not sure whether she's talking about a pooled income trust or an asset trust, but if it's the pooled income trust, you can at any time stop that. You just stop depositing your monthly income. If we're talking about a trust that is designed to help make you eligible for Medicaid, that is probably going to be an irrevocable trust. And I'm going to talk about that a little bit later in the program.
Okay, great. Good.
When I say irrevocable, I mean not revocable, not changeable, no authority to take back the money that you put into it.
And the last question, which I think is probably too specific for this discussion, what do you do with 457 or 503B monies in a pooled trust? I don't know whether that's too involved for this discussion.
Well, if we're talking about retirement plans, if you are taking at least your required minimum distribution, then the principal and the principal amount in the retirement plan is not a Medicaid resource. But the distribution, the minimum distribution or whatever distribution you take, is income for purposes of Medicaid and for purposes of the IRS, by the way, unless it's a Roth IRA. Okay, let's move on to, are we ready to move on, Cindy?
Yes. Yes, we are.
Okay. So in the previous slide, I had asked the question, if we want to become eligible for Medicaid, to whom are we going to transfer our money or property? So one answer might be, I'll transfer it to my son, my daughter, my cousin, my niece or nephew, whoever that might be. That may be an okay choice. It certainly works for Medicaid, because if you make a gift to a child or a sibling or a friend, once you've made that gift, that transfer, that money or that property is not yours anymore. It's the property of the person that you gave it to. And let's say this is all done with the best of intentions. We trust our children or our siblings. They will hold on to that money and use it for my benefit if I'm making the transfer. There are other risks involved, apart from misuse of the money. What if the person to whom you transferred your money with the idea that they would hold on to it and use it for your benefit, what happens if they predecease you? Now your money is in their estate. What if they're married and they've got marital problems and they wind up getting divorced. Your money is tied up in the divorce. What if they have financial problems of their own and they have creditors and obligations? Your money may become involved in all of that. So very hard to predict or quantify these kinds of problems, but we can't avoid the fact that the risk is there. And the further point, which is the last one on this slide, just to explain it, when you inherit assets from someone, whether it's a house or securities or something else, you as the beneficiary receive that asset at its current value. And what that means is that if that asset has increased in value over the lifetime of the person who left it to you, we have capital gain, but that capital gain is not taxable anymore because you receive the asset at its date of death value. So just to give you a concrete example, let's say your mom or your dad bought a house 40 years ago and they paid $25,000 for it. And today, that house has dramatically increased in value. It's now worth $1 million, right? So if mom and dad sold that house during their lifetime, they would have to recognize a pretty big capital gain and pay a fair amount of tax as a result of the sale of the property. But if you inherited that property from them, you would receive it with $1 million value. So if you sold it for $1 million, you would not recognize any capital gain and you would not pay any capital gain tax. So this is what we mean, or what tax lawyers mean when they say there was a step up in tax basis. You got the higher date of death value and therefore you avoided capital gains tax. Now, it comes into play here with transfers, because let's say mom or dad transferred that house to you during their lifetime. Now, you do not get a step up in basis. You get the same tax basis that they have in the property. That original $25,000 that they paid for it is attributed to you, so that if you sell the property, you have to recognize that big capital gain and pay the capital gain tax. I hope everybody followed me on that. I know it gets a little complicated, but it's a very important feature sometimes when we have a situation where somebody owns property or securities that has appreciated in value. Okay, well, certain transfers are exempt under New York's Medicaid law. If we're transferring money or property to a blind or disabled child, or we're putting it in a trust for the sole benefit of someone who's disabled and under the age of 65, we can transfer our home to a child who has lived with us for 2 years or more. We can transfer our home to a sibling who has an equity interest for 1 year or more. And finally, we can transfer to a spouse. And the spousal transfer does not even create a problem for nursing home Medicaid. It certainly causes no problem for community Medicaid. But when the spouse is the recipient, Medicaid does have the ability to come back to the spouse at a later time and ask for some reimbursement. So the spousal transfer may be a useful tactic in some cases and not in others. So that brings us to the trust solution. And the type of trust that we're talking about here, one that will facilitate eligibility for Medicaid and that will protect your home, your investments, whatever property you wind up putting into the trust, that will be an irrevocable trust. And that's to distinguish it from revocable trusts, which are sometimes called living trusts. Those are trusts that you can be your own trustee, you have complete control, you can revoke the trust, you can amend it, you can put assets into it, you can take assets out of it, you can do whatever you want with that revocable trust or living trust. But that is not the kind of trust that helps you with Medicaid. It is the revocable trust. It is a trust that keeps your estate out of court. Nobody has to engage with a probate proceeding or have any other court proceeding to distribute assets through a revocable trust. But it doesn't protect those assets and it doesn't help you with Medicaid. For that, you need an irrevocable trust, one where you have an independent trustee, someone other than yourself or your spouse. It could be your children, could be a sibling, could be a friend, anybody you want, as long as it's not you or your spouse. So your trustee is charged with administering your trust. You cannot change the trust. You cannot revoke it. You cannot take it back. You cannot demand that assets be given back to you or that your bills be paid from the trust. So it's a big step. It's an important step, but it is a step that gives you access to New York's Medicaid program. And it does it in a way that it will protect those assets from all comers, including Medicaid. And it will give your beneficiaries a step up in basis of appreciated assets. It will contain your estate plan and keep it out of court. So all good news with your irrevocable trust. You just have to accept the fact that it requires an independent trustee. Now, here's a question that we get asked all the time. I've heard that my home is exempt. Isn't that true? Isn't my home exempt? So, there's some truth to it, but not enough that you'd want to rely on it. Your home is exempt as long as it's your primary residence and that the home equity is no more than $1,071,000. So the problem with it is that we know that a day will come when your home is not your primary residence. That day will come if you move into an assisted living, or you need to go to a nursing home, or if you die, we're all going to die someday. Then your home is no longer exempt. and Medicaid's going to put a claim against it, a lien against it, and ask for reimbursement from the home equity. So if we're thinking about Medicaid or applying for Medicaid, we do not want to leave the home in your name on the theory that that it is exempt because it's your primary residence. That will only work for a while until it's no longer your primary residence, and then we have a big problem. So you really want to protect that home? Probably the answer is going to be to put it in a trust. And that would be the safe thing to do. So I think I've pretty much covered here accessing the Medicaid program, and I want to turn things over to Tara at this point, and she's going to talk to you about what to do once you have established your eligibility for Medicaid. Okay, Tara.
Okay. Hi, everyone. Thank you so much for having us on today. Okay. So,
Before Tara gets started, sorry, I just want to say that I'm sorry, there's a few questions that we didn't answer, but I just, in the interests of time, we are going to, we're just going to move on to Tara. So if we have a little bit of time at the end, I'll ask the other questions in the Q&A, but thank you. But we are trying to get to Tara. Okay, so Tara, go.
okay. So the Medicaid application is, the first and foremost way to get long-term care. Once the Medicaid application is approved and you receive an active Medicaid ID number, what you do is you contact New York State Department of Health, and you need to schedule 2 assessments. Those 2 assessments must be done by the New York State. It's called the New York Independent Assessor. And basically, it's just Medicaid's way of making sure that the patient through that Medicaid number is qualified for home care. So there are several steps involved in completing the evaluations before you can enroll into the next portion, which is the MLTC, to start receiving that care. David, you can go to the next one.
Okay.
Okay, so,
Sorry.
okay, so the New York Independent Assessor. So this is New York State. It's through New York State Department of Health. Basically, you just call up the New York State number. It is given to you in the approval notice by Medicaid, the number to call. And during this assessment, a New York State nurse does an evaluation and will be writing down the individual needs of that applicant, and then including any additional information that is necessary to determine eligibility for home care. The next assessment, once done with the initial, is done by the independent practitioner panel. And it's to determine whether the applicant can safely receive that care in the home. So it is to make sure that the applicant is safe in their own home. And then based off of those 2 evaluations, you are either denied or approved. So if you are denied by New York State Independent Assessor, you can request a fair hearing and proceed from there. If you are approved, then you will be sent an approval notice with the next steps regarding the MLTC. Okay, so MLTC, it stands for Managed Long-Term Care. So it's basically an insurance that attaches to the Medicaid. And for the most part, the primary reason for this is strictly for home care. So it can offer additional services, but for the most part, MLTC is strictly for long-term care. Once the 2 assessments through New York State are done, that's when we would contact these individual MLTCs. So a few examples of an MLTC. Visiting Nurse Service has it. It's called VNS Health. You have Centers Plan for Healthy Living. Blue Cross Blue Shield has one. And it would specifically have to be an MLTC, just like you have an HMO or a PPO. MLTC is its own version of an insurance specifically for long-term care. So what happens now is that MLTC comes into the home. It can be via Zoom or face-to-face. And they do their own evaluation with a printout of the evaluation done by New York State. And it's basically an evaluation of an evaluation, and then just them seeing what is needed in the home. So if there's, you know, a commode that needs to be ordered, or a shower chair that would be, you know, helpful, or grab bars, any assistive devices. That's really what the idea behind having that assessment is, just to include more accessible options for that patient. I always recommend scheduling more than one MLTC assessment, because every insurance plan is going to give you a different number of approved home care hours. And then from there, you can determine which MLTC is the right fit for you and your family. If the MLTC offers more than 12 hours per day, it does have to go through the independent review panel. And it's basically just to determine whether or not the person who is applying for home care can safely remain at the home. It's more of a liability thing than anything else. When you need that constant, you know, round the clock care, they need to make sure that everything is in place for them to stay safe. The MLTC is not going to approve supervision hours. So for MLTC, it is strictly for daily living activities. So you need to prove that you need help with getting in and out of the shower. So bathing, toileting, cleaning, you know, if you need help getting in and out of bed, basically day-to-day living activities are what is being evaluated, and then would determine eligibility and how many hours you would get. Next. Okay, so once you have the assessment through the MLTC, that is when you decide whether or not you want to go through the consumer-directed program or the personal care program. So I'm going to go into detail between the two. The acronym for consumer directive is called CDPAP. I'm sure a lot of people have heard it over commercials. It's a very popular program. It is very different than the certified home health aid. So I'm going to just go in, I'm going to start with CDPAP. So some pros are that you can get additional care than what a certified home health aid would offer, because the family is the one who is training the CDPAP. So the family can train the CDPAP to do tracheostomy care, including suctioning, oxygen administration, medication administration, medication injections like insulin if needed. Also setting up and using medical equipment like a ventilator. When it comes to tube feeding and sterile wound dressing of injuries, the family will have to teach the CDPAP how to perform these tasks, but they are allowed to do it. And it can be a family member or a friend who is hired. So they do not have to be a certified home health aide. They do not have to take a class. Some cons for being part of the CDPAP route is that the family is responsible for finding those aides basically, and scheduling them, including, you know, just keeping track of, you know, how many hours they're working and reporting it for payroll. When you're doing the CDPAP option, if that person that you have registered as a CDPAP does not show up for work, it is on the family to find a replacement. And if there's no other person that is signed up for that patient, then no other person can work. So it's a little bit hard when you have somebody who needs 24-hour care and you don't have enough CDPAP signed up for that specific patient. And also, you know, it can be a con for a CDPAP to not require a 4-week certification course because there is no required education. So I'm going to jump down to personal care aides. So I'm going to start with the pros. This is more on the agency. So the agency is responsible for finding staffing for the patient. So if somebody calls out, it's on the agency to call up other home health aides and find somebody to fill that slot. The agency is the one that will be handling payroll and scheduling for the home health aide. And it is a better option for somebody who maybe doesn't have family nearby to coordinate that care. Some cons for the personal care aide is that it is the aide that is coming to the home is not somebody that the family knows. So you know, the aide is initially a stranger to that customer. It can take a few tries to find the right home health aide for the patient. So you want to make sure that chemistry is, you know, something that is appropriate, and you know, it's not always given the first time somebody comes in that it's going to be a good chemistry match. They are not able to administer medication. They are a personal care aide. They are not medical. So they are not able to perform any medical tasks that is not their certification. So CDPAP, you can be trained to do that, but a certified home health aide, you are not allowed to. David, next slide. David. Thank you. So I'm going to also talk about the another program. It's a New York State waiver program, and it's called the Nursing Home Transition and Diversion Program. This is separate from an MLTC. So the NHTD program is a home and community-based program that helps New York Medicaid eligible seniors and people with a physical disability receive comprehensive services they need while they live in a community-based setting. So instead of living in a nursing home or a congregate care setting or institution, they can live at home with nursing home level care. The concept is to provide 24/7 supervision and care in the community, mirroring a nursing home. So highlight supervision here. Nursing home transition diversion is a supervision program. This program is responsible for the participants' health and welfare within the community. So there are some criteria that the patients have to prove in order to be eligible. First one is they have to be eligible for Medicaid. This is a Medicaid waiver program. Based off of these assessments, they need nursing home level of care. And they have to be verified with a physical disability between the ages of 18 to 64 or 65 or older. The applicant must be living in the community while receiving MLTC services. So you do have to go through MLTC in order to qualify. And one of the very important criteria here is that you have to have a cognitive or a neurological decline diagnosis. So dementia, Parkinson's, Alzheimer's, anything that shows that there is that progressive cognitive decline is very important for this program. And although you're already receiving the MLTC services, you have to prove that MLTC is denying any requests for an increase of hours. So, you know, if the patient is already receiving, let's say 8 hours a day, and they go back to MLTC and ask for an increase, and they say, no, we're not paying for supervision, you know, there's no other ADLs that we see that the patient needs, we're not going to give any more than the 8 hours a day. That denial letter is what NHTD needs to see in order for them to be approved through the program. Okay, next one. Oh, and that's it.
Okay, it's good because we have quite a few questions, and I wanted to hold the questions a little bit, just so that Tara could get through her part.
Sure.
So let me, I'm going to go through the questions, and I'm going to try and get them sort of in the order. Let's start with Tara relative questions. So somebody asked, in terms of hours of care, how do they categorize hours of care? Is that hours per day or hours per week? What's the?
So the MLTC will give a specific amount of hours per week. And sometimes, depending on the MLTC, they will give hours, like they'll divvy it up per day. Some days will be, you know, if it's 35 hours a week, you might only get the care on Monday through Friday, but you can fight that if it doesn't fit for your schedule. So they usually just give that lump sum for the week. And then you work with them to determine how many hours each day you want to use.
Okay, great. And then somebody else said, so you can get you can be eligible for Medicaid, but not be approved for an MLTC. Is that possible?
So being approved for MLTC is based off of your need for home care. So to qualify for Medicaid is, you know, is very different than the actual MLTC like application process. You have to prove to New York State that you are in need of the care at home. And then based off of that New York State assessment, that's what the MLTC looks at to give you a specific amount of hours approved.
Okay. And you might want to talk about the assessment process and how it can sometimes help to have an advocate there. So I know, so we have, you know, one of the reasons that we hired Tara was that people sometimes when they go for the assessment and the older person says, well, I can take a shower by myself, I can get dressed by myself. And then the MLTC says, well, then if you can do all this by yourself, you don't need care. When, for example, my mother-in-law said that, but then the person that was assessing her said, well, let's see, why don't you get into the shower? And when she got into the shower, she almost fell. Okay, so she can do it, but she couldn't do it safely. And then she said, well, do you put on your compression hose? Well, no, I can't get those on. Well, she was supposed to wear compression hose, but she couldn't get her compression hose on by herself. So she did need assistance with that activity of daily living. So like explain that when you go through the assessment process, how it's really, you want to manage it to the extent that you can, if you can describe that a little.
Yeah, I think every family dynamic is a little different. You know, when you're doing this for a parent or a grandparent, for the most part, you know how they are going to answer specific questions. And I think everybody has to be ready to swoop in and, you know, correct if wrong. So like Cindy said, you know, a lot of these questions are anybody's first instinct is to say, oh yeah, I can do it, no problem. And you have to work with that patient to really put the pride aside, because if you say that you can do something, that's going to work against you when trying to get care. Yeah. So, you know, if the assessor asks somebody, oh, you know, do you have a hard time getting out of bed? And, you know, the patient says, oh no, I can, you know, I'm fine. I can get out of bed just fine. I always recommend there being somebody on the assessment to advocate for that patient, because if there needs to be a bed rail or, you know, an additional hand to get somebody out of that bed, it needs to be addressed. Anybody who's doing this assessment is very quick to say, oh no, I have no problem doing it. But that's not what you want to say, right? Because that's going to be held against you. So I always, you know, when I work with families, this is my job to really just sit alongside the family members and the patient during these assessments, and really just push for what is needed in the home. So, I always like to ask the questions before the assessment, like, how are you going to answer this? A lot of clients are very quick to say, oh, I have no problem walking. Okay, but do you need an assistive device? Do you use a walker? How far can you walk? Are you holding onto the walls? These are all these follow-up questions that the assessor isn't always going to ask. And it's always good to have that on that face-to-face with the assessor. So they see that, you're questioning what is being said there, and it is documented, because it does come down to liability. We don't want to say that, oh, we have no problem walking, when in fact you do. And then you're given, let's say, 2 hours a day, and now you're a fall risk at home and you're not getting the proper care. So I always say that, at the end of the day, this is one portion of the long-term care process where you have to put that pride aside and be very truthful about every question that is being asked. And if it's not being truthful, you need to have somebody on the call or at the assessment to really advocate and correct.
Okay, great. Exactly. Good. Somebody asked, can someone get MLTC hours and not have Medicaid?
No.
No. And yeah, okay, good. Didn't think so, but okay. And is it, so here's a question. I'm not sure, 3 questions. Is there a minimum hours given to someone who has Alzheimer's? I'm just asking you the questions as they're presented.
No, it's based off of a full assessment. It's not based off of a diagnosis. It's based off of a full assessment.
Good. How is the ADL? Is there like a metric for the ADL score? There is, isn't there? Yeah.
Yes. So I believe it's a score up to 50. Basically, the closer to 50, the more hours that you could be eligible for. I've had a client score 48 out of 50 and only receive 5 hours a day of care. So it really, it is a toss up. But the score is calculated based off of the questions that are asked. So the more ADLs that you need help with, the higher the score. Again, supervision is not paid for by MLTC. So that is very different. It is strictly on ADLs.
And is there a way to find out what the questions are so that the person can sort of prepare ahead of time?
That's a good question. There
I
really
mean, it just
isn't, like
occurred
I
to me
said,
because if there is a score, then there must be a list of questions that they're asking. And it would be helpful to know what the questions are before they ask them.
I don't know if you can find that anywhere. I know that it is based off of each client that comes on. And each evaluator is going to ask in a different way. So I'm not sure. I'm sure they have their own protocol, but I've never seen a written out, question by question, printout of what is asked.
All right. Is it true that a POA or healthcare proxy is ineligible to participate in CDPAP? I'm not sure what that means.
Yes, so you cannot be a CDPAP if you are a healthcare proxy or a power of attorney. Unfortunately, it just becomes a
you can't be an assistant. I mean, you can't be an aide because you are the power of attorney or you're the healthcare proxy, whatever. There's an inherent conflict of interest, you said?
Yes.
Okay. Good. All right. Let's see. So the information from this presentation, well, the presentation is being recorded, so that's there. But if you want the specific slides, I would say email us, and we will send you we can send you the slides. They are copyrighted, so we don't want you to use this information, for your own purposes. But we can send you a printout of a file with the slides in it if you want. So just email, please email us. And yeah. Okay, let's see. Okay, so those are the Tara questions. Okay, so now I'm going back to the, so somebody said, what if you don't have anyone to manage the irrevocable trust? And I said, I am not a lawyer, so nothing that I say can be construed to be legal advice, but there are people who do, and people that we know who serve as trustees of trusts. So David, do you want to respond to that a little bit?
Yeah, I mean, that's not an unusual request. We do have clients that are alone, who have no family member or person close to them who they feel is capable or desirable as a trustee. We can recommend professionals who will serve in that role. And what we typically say to clients is, look, we can introduce you to people and, see if you like, this person, great. If you feel comfortable, we know that they're professional, they're insured, they've done it before. So there is some help there if you're willing to look in the direction of a professional trustee.
And sometimes people could, for example, name one of their children as a trustee, but if the child is not good with money or needs assistance, they could ask an institution to be, or a company that does this to be a co-trustee. Is that correct?
That's also correct. You could name a co-trustee. So that, that also comes up there. But again, there are professionals who will accept to work in that role as a trustee, as an agent under a power of attorney, that kind of thing. Yes.
Okay. Next, can you explain spousal refusal and how that may impact a married couple applying for Medicaid?
Yeah, well, it all starts with a law that's not a Medicaid law. It's a part of New York's laws of general obligations. And spouses have obligations of support toward each other in the same way that parents have obligations of support for minor children. So what happens in the Medicaid context is this. The spouse who needs care transfers his, let's say it's the husband, and he needs to go into a nursing home or he needs home care. He transfers the assets that are in his name to his wife, his spouse, so that he has no more than $31,175 in his name. And she has all the money, right? So Medicaid will, and I'm putting this kind of in a colloquial way, but Medicaid's going to come to her and say, look, Mrs., your husband needs care. You should take care of him. Why don't you do that? And she says, in effect, look, I've been taking care of him for a long time. I'm just not going to do it anymore. I refuse. And there's actually a Medicaid form that's called the spousal refusal form, because they expect spouses to refuse. So, okay, sign here, you're refusing, and it's the spouse's refusal to provide support for the husband or whoever the spouse is who needs care that forces Medicaid under New York law to provide the care. All right, so now the husband is in a nursing home, or he's getting home care, or he's in an assisted living and Medicaid's paying for it. And a few years go by, or he dies. Medicaid can come back to the refusing spouse and say, look, we just spent $300,000 on your husband. We want to be reimbursed. So there are a couple of things to notice about this. One is it's not automatic. Medicaid actually has to come forward with a claim. The second thing to notice is that the amount is based on what Medicaid paid, not what you would have paid if you had been paying on a private pay basis, because Medicaid gets a very discounted rate, whether we're talking about nursing home, assisted living, home care, whatever it is. Medicaid is paying at a lower rate than the private person would pay. So you've already got kind of a built-in discount. And the next thing that happens is, since this claim is probably coming from a collection agency that's working on behalf of Medicaid, they just want to make a deal and get some cash. You can negotiate with them. And typically you're going to offer a pretty big discount, so maybe you're only going to pay 50 cents on the dollar, some number like that. As a result, at the end of the day, you've paid a very big discounted amount, although it still may be a real number. But that's how spousal refusal works. And it comes into play most often, I think, in the nursing home cases. If your spouse needs to go into a nursing home and you're confronted with that 5-year look back, you may have no other option. But at the end of the day, you're still going to pay a heck of a lot less than you would have paid if you'd been paying the private pay rate all along.
You could say that there is a minimum amount. It's not very big, but there is a minimum amount that below which that the spouse is allowed to keep. The community.
It's the community spouse resource allowance.
That's it. Yeah.
I think you're asking about, Cindy, which is currently $154,140. So if the spouse has no more than that number, 154,000, they're not going to bother you. Medicaid's not going to come back and ask you for a contribution or reimbursement rather, because you're under the community spouse resource allowance. But if you're sitting there with several $100,000, they're likely to come and say, look, time for you to reimburse us.
Yeah. Okay. Next, does the home have to be an irrevocable trust, or can it be in a revocable trust?
Well, as I said, a revocable trust is not going to help, because you have access to all of the money and property in a revocable trust, because you can revoke the trust and you can remove assets from the trust. So if it's a revocable trust, Medicaid's position is, and I think it's the correct position, you have access to all of this money. It's all available to you. Therefore, we're going to count it as yours.
Yep. Okay. Somebody said, I heard there is a bill to stop Medicaid from going after your home. Is that true?
I don't know where you heard that. I don't know. I haven't heard that one.
Yeah. Okay. And let's see. Can monies in an irrevocable Medicaid trust be used for the benefit of the grantor? Smart, good question.
The answer is yes, if it's done correctly and properly. So to start with, the trust cannot return any money or property to the grantor, must not do that. And the trust must not pay any of the expenses of the grantor. All right, so on the face of it, the answer is no. What the trust can do is in the discretion of the trustee or trustees. The trust can distribute money during the lifetime of the grantor to beneficiaries that the grantor has allowed in the trust document to receive distributions during lifetime, right? So let's say the grantor has 3 children and has named one of them as his trustee. And the trust provides that during his lifetime, the trustee can make distributions to his descendants, right? His children or grandchildren. So the trustee decides, I'm going to distribute $10,000 to my brother or my sister. So once that money is received by the brother or the sister, it's their money, right? It's not trust money anymore, it's their money. So if they decide that they want to spend that money on dad, that's their decision. It's voluntary on their part, and they can do that. So I know it sounds circuitous, and some people say it sounds like a loophole. Yeah, okay, it really isn't. It's a permitted distribution from a trust, and the recipient has voluntarily decided how to spend his or her own money. It does not implicate the trust. So that's how it would have to be handled. But the trust must not distribute money to the grantor or pay the grantor's bills directly.
So we're getting toward the end, so I don't want to go over too long, but let's see. Two questions, if you can answer quickly. We try not to be pushing our services because we really want this to be educational, and I think we are educational. But somebody asked, how or where do you get the Medicaid application, and does your firm assist with applications before submission?
Well, I mean, the applications are, available from New York State websites if you want to see what the form looks like. But, and I think you need to understand that a Medicaid application it's a real project. It's not filling out a 4-page form. There's a lot of documentation and information that must be provided together with the form. So you don't have to be a lawyer to prepare and submit a Medicaid form, a Medicaid application. You can try doing it yourself if you wish. We've had clients that decided they wanted to do their own applications. Oftentimes they haven't succeeded. It's a project. You need to know what you're doing.
And if you're spending money, on care, so I was going to say, if you're spending money on care while you're filling out the form, if an elder law attorney can help you get the process completed more quickly, you're saving. That's a savings as well. Yeah.
Well, I think elder law firms, ours included, we prepare a lot of Medicaid applications for clients, and we have a very high success rate. 100%. So, you just need to know what you're doing. And so we're happy to help if desired. As I said, though, you're not required to have an attorney to do it.
Yeah. Okay. So there's just brief. This was in the chat. I've worked with many clients who get Medicaid, but have houses outside of the country. It would appear that New York Medicaid isn't paying attention. So can you address that?
Well, I don't know what they're paying attention to or not paying attention to. If you own property outside of the country, that is certainly something that we will take into consideration in preparing an application, because otherwise somebody is committing Medicaid fraud. So, you know, if somebody feels that they want to take the chance of doing that, you know, I don't advise it, and it certainly, we would not submit an application that ignores assets wherever they may be, whether it's foreign real estate or a foreign bank account or whatever. If it belongs to you and you're applying for Medicaid, it is part of the application. So I don't know what New York State is doing in that regard. You know, you know, I like to say this: early in my career, I was a federal prosecutor, and my comment on this subject is, I never met a defendant who thought he was going to get caught. So I don't know. I sort of believe in let's do it the right way. We're not looking to take risks here, at least in our firm. We're certainly not going to do that.
Yeah. Okay. So, how different is it in Florida versus New York? That's a question.
Well, you know, I really don't know the specifics of Florida's Medicaid program. It's different than New York's. Every state has its own program because Medicaid is a partnership program between the states and the federal government, and the program is administered by the states under state law. So I do know that we've had a fair number of clients who moved to Florida on retirement, and when they needed long-term care, they wound up moving back to New York so they could take advantage of the Medicaid program here. But we've also had clients who moved to Florida and asked us for a referral to Florida law firms that could help them with their Medicaid, and we've certainly done that also. I would not put Florida in the category of the states that have terrible programs, and I'm sure they have a decent program. But I really can't say more about it than that.
Okay, and sorry, one last question popped up, and then I think we really do need to wrap it up. Can income generated by trust assets be used for the benefit of the grantors? So the ordinary income, for example, of a trust. Can it be used for the benefit of the grantors?
Yes, in the trusts that we typically prepare that are designed to facilitate Medicaid eligibility, we provide that all of the net income earned by the trust is paid at least annually to the grantor, because it's income. So as we already learned from the beginning of the program here, income does not affect your eligibility for Medicaid. It may impact your need to use a pooled income trust to protect that income, but you certainly can have more income, and you certainly can have the income produced by trust assets. You just can't have access to the principal amounts. And the other part of it too is that when a grantor retains the right to receive the income from the trust assets, it means that the grantor's gift to the trust, or the transfer of that asset to the trust, is an incomplete gift. Therefore, it has a tax consequence of putting that asset into the taxable estate of the grantor, which has the further consequence of giving the beneficiaries a step up in basis of the trust assets. So in the typical case that we handle, that is a desired tax effect. we want that step up in basis so that the beneficiaries can avoid capital gains tax. And we don't care about putting the asset into the taxable estate because we know that the exemption amounts are so high that the client is not going to pay any, or the client's estate is not going to pay any estate tax. And just to take a quick look at that, your federal exemption right now is $13,640,000. So your estate would have to exceed that amount before you're going to worry about federal estate tax. And in New York State, we do have an estate tax, but your exclusion is, or exemption is $6,910,000. So, you know, the exemption amounts are very high. Most people are not, don't have estates that large, so they're not paying estate tax.
Okay, so you know what? I'm just thinking that I think it's going to be easiest for me just to tell everybody who attended that I will send them a file with the presentation in it. David, is that okay?
That's okay.
Okay, so so in the next day or two, you'll get a follow-up email from us with the presentation in it. And this, since it's being recorded, it's also going to be put up on the PSS website in a little bit. I'm not sure how long. Maybe Matt can address that. And yes, so I think we're going to wrap it up now. Thank you, everybody, for all the questions. They were very good.